So, I will talk about the use of interferon in melanoma patients, but what do we know about interferon in melanoma patients? We know that interferon is largely used as adjuvant in melanoma patients, and from the recent meta-analysis we know that the absolute benefit of interferon is of 3%, is low, but is consistent with the percentage of other adjuvant treatment in other cancer disease. And we know from the last meta-analysis by Simone and Mocellin, published on JNCI in 2010, and considered more trials and more patients, that the relative risk reduction for disease-free survival and overall survival is 18%, and 11% for overall survival. This 11% may be translated into 3% found by Whitley in the previous meta-analysis. And this independently by the dosage, the duration, and the route of administration, if intravenous or intramuscular and subcutaneous. We know also that in advanced disease, interferon is not effective, unfortunately. For several years, there was a large debate. The debate is still ongoing about the duration of this treatment and the route. And several colleagues consider the duration more important because in some trials like WHO, we had the banana-like curve. What does it mean? This means that during the treatment, and some of these trials, the treatment was for 3 years, patients, normally the majority of patients have no recurrence, but at the stop of the treatment, the patients recurred. But we know from other trials that this is not true, also from trial that considered the treatment for also 5 years. And this is one of the reasons because at the moment the topic about the duration is not a hot topic. The problem is to identify patients who respond to interferon and patients who don't respond to interferon. Several years ago, we did a little experience on patients who were treated with interferon, with low dose interferon and recurred. And after this, we increased the dosage, but all these patients recurred again. At the time, we suggested that the main topic is to identify responders or not. And we believe that today is probably one of the main issues about interferon treatment in advanced in melanoma patients, adjuvant patients. We know also that those are effective for the German trial published some years ago. But the most important question in these patients is what is the mechanism of action of interferon? As Filippo mentioned in his talk, the mechanism of action is cytotoxic or immunomodulator mechanism of action. We know today a lot of things about this, and especially thanks to the experience of John Kirkwood in Pittsburgh. And we know that probably the most important mechanism of action is an indirect immunomodulatory for the high dose interferon, because the majority of experience was in this kind of treatment. One of the most important evidence is the increase in the tumor infiltrating cell in patients who are treated with high doses of interferon. This was observed by John and this group in this neoadjuvant trial. That is to say, patients were treated with high-dose interferon with the 4 weeks with intravenous high-dose administration, and then patients underwent to the surgical excision of the lymph node. And really interesting, the patients who responded to high-dose interferon increased the CD11C and CD86 more than the no-responder patients. Another important evidence is the development of autoantibody and clinical manifestation of autoimmunity. This was reported in New England Journal of Medicine by Helen Gorans and the Hellenic group. It was really interesting because it was considered one of the most important factors for as prognostic, more than predictive for response to interferon. This was observed also in the arm with the treatment just for 1 month of intravenous injection respect to the 1 year treatment of the other arms. Unfortunately, these data were confirmed in some trial, but was not confirmed in the large ORTC trial. because in this trial was considered also a time-dependent model, 3 different models. And these models were based on the basis of the appearance, the occurrence of the development of this autoantibody. And if we consider a time-independent Cox model, there is a correlation of between this development and outcome of these patients. But this is missed if we consider a time-dependent model, so there is no correlation. This was seen in 2 trials, the OTC 18952 trial and the Nordic trial with the low intermediate dose of interferon, but was also seen in the PEG-intron adjuvant trial from OTC. Also in such case, the time-dependent cost model showed no correlation between the occurrence and development of this autoantibody and relapse-free survival, overall survival. And also the seroconversion in the 2 halves, observation halves, the PEG-intron trial, as you can see, was not significant. So also in such case, there was no correlation about this autoantibodies development and outcome of these patients. Another important evidence is the balance state 1 and state 3. We know that this pattern is important in the mechanism of action of interferon. We know that high-dose interferon are able to upregulate the phosphostate 1 and downregulate the phosphostate 3. And the ratio, of course, increases. This may be important for the immunomodulatory effect of interferon. Also, these data were provided by John Kirkuk and this group. Also, the upregulation of type 2 is important and may be related to these mechanisms of action. Another important evidence is the change in the serum concentration of some cytokines. This was observed in another important trial, the EGOG trial, the EGOG 1894. This was a trial which compared the high dosage interferon to the ganglioside vaccination. And really interesting in the high dose interferon arms, after the interferon treatment, it was observed an increase of some cytokine related to the immunoresponse, but not of some growth factor or androgenic factor like the VEGF. Of course, this evidence was made in the serum of this vision, but it's really interesting. And also interesting in the group of patients treated with high-dose interferon that patients who had a long relapse-free survival had the highest value of this cytokine with respect to the patients who are treated with ganglioside vaccination. Another interesting evidence about this mechanism of action was done by Peter Lee group, and it's really interesting, and he noted that patients, the lymphocyte of melanoma patients had downregulation and low expression with the phosphostate 1 respect to the healthy donors. Really interesting, in a vitro experiment with the dosage of interferons, dosage that can be compared with the high dosage from the adjuvant treatment. It's interesting that after the exposure to this dose of interferon, we had a normalization of this state 1 with an increase of the phosphostate 1. And this is interesting because it was also observed on patients treated with interferon and on circulating lymphocyte, on PBMC, that patients who had elevated phosphostate 1 levels had a better prognosis, a better outcome with respect to patients who had a lower level of the phosphostate 1. So, of course, this may be interesting and may be an important factor because it's hard to do in our patients, but, of course, this may be a good point. Another evidence from my group was the decrease in circulating T cell. Of course, this was done in a small cohort of patients, but it's interesting because also in such case, this decrease can correlate with the outcome of this patient. Anyway, we have this clear evidence of an indirect immunomodulatory effect, but of course, this is the past. We need to be projected to the future, and the most important points are, in my opinion, 2 points. First, to identify patients who respond to interferon in order to optimize this kind of treatment for adjuvant patients, and most important, to find some possible combination, because we just heard that combinations are better respect to this single agent treatment that can improve the efficacy of interferon. About markers, there are a lot of markers of molecular markers, but we have no time. I'd like just to discuss about one marker that at the moment is exploring in clinical trials, the ulceration. You know that the ulceration in melanoma is the loss of continuity of the epithelium, and in melanoma this is related to a wrong prognosis. You can see in the dotted line the patients who have a primary lesion with ulceration, and these patients, the outcome is bad respect to the patients without ulceration. And this is interesting because some evidence from the EORTC trial in the adjuvant setting of patients showed that the presence of ulceration in primary lesion was related to a better outcome. This was true for all the population, but mainly for the population, for the patients who had low tumor burden or no lymph node metastasis. At the moment, there is a clinical trial that is exploring prospectively this treatment and this evidence of a better response to interferon in patients with the primary lesion ulcerated, and we will see. But it's really interesting, an hypothesis that we generated together with Soldano Ferrone. You know Soldano Ferrone, a famous immunologist, and you know that it was described several years ago that interferon is able to upregulate at HLA1, and it's interesting that the HL1 is not expressed in ulcerated melanoma, while it's well expressed in non-ulcerated melanoma, as you can see in this experiment from our pathologist, Gerardo Botti. And we found in a cohort of 170 patients that, of course, in the ulcerated lesions, we had low expression of HLA1, while in the not ulcerated we had high expression, and an hypothesis may be that interferon may increase in the ulcerated primary lesion, the HL1, and this may be translated in a better response to interferon. Of course, this is just a suggestion, but now we know that for melanoma patients it's important to know the mutational status, because we should divide, we should split advanced melanoma patients to different groups, the mutated group and the wild type, and the BRAF mutation is the most important mutation. And one question may be, is the interferon has the same efficacy in patients who have the BRAF mutation? This is interesting because we found together Soldano Ferrone, when he was in Pittsburgh, that in some melanoma cell lines, the presence of the BRAF mutations was related to a downregulation of the interferon receptor. And the use of BRAF inhibitor, vemurafenib, was related to an upregulation of this receptor. And in melanoma cell line, not only normal melanoma cell line, but also resistant to BRAF inhibitor, as you can see on your right, the combination of BRAF inhibitor, vemurafenib plus interferon, increased the cytotoxic effect on this cell line. And also in mouse models, the combination, the red line, worked better respect to the single agent treatment. Of course, this is important because it may be the basis for a possible combination, and we are starting in the next days, we will enroll our first patient, this combination in advanced melanoma patients. And this is a phase 1 study, and we have also biological endpoint, the assess of the interferon receptor in biopsy of these patients after the treatment at baseline and after treatment with the combination. And we are eager to explore this combination, of course, because the preclinical model was really, really interesting. Another possible combination, of course, is the combination of interferon with the anti-CTLA4. And always John Kirkwood did this experience in advanced melanoma patients and was really interesting, not with the ipilimumab, but with the other anti-CTLA4, the tremelimumab. And this is interesting because if you see the median overall survival time is 21 months, this is really interesting for melanoma patients. Of course, we need to explore this in perspective in phase 3 trial, but may be interesting. But I think that the most interesting combination may be with the PD-1. We know the importance of PD-1 and PD-L1 interaction as immunosuppressive, and really interesting data provided by different colleagues, and these are the data provided by Liping Cheng from Johns Hopkins. The interferon is able to increase the level of B7H1, the PD-L1 melanoma cell. So this may be, of course, the background, the rationale for a possible combination of interferon with the anti-PD-1. In conclusion, and I think that I stayed on time, Enrico and Guido, I think that the future of interferon should be now not discussion about the dosage and duration in adjuvant setting of patients, but the possible combination for advanced melanoma patients and probably also for the adjuvant treatment in melanoma patients. And thank you.
Thank you, Paolo.